So good morning, good afternoon, good night, or good evening. Dear friends and colleagues, welcome to the 8th CSRS webinar. Despite a favorable course of COVID-19 pandemics, medical education is still effective and many courses have been canceled. Still, as it is the case of our CSRS course, the Cadaver Lab course in Barcelona, due to happen in March. And also, I believe that to a certain degree, this form of medical education through webinars, it's here to stay. There are many positive aspects of this kind of educational program. Today, our webinar is in some way the reverse of a previous one that we have done on implantless cervical spine surgery. As you all know, the numbers of cervical spine instrumentation are rocketing. So it is important to have a clear idea of the correct use of cervical screws and proper placement to avoid complications, reoperations, which represent a burden to limited healthcare resources. So we hope to cover in a comprehensive way the indications, the tips and tricks for a successful outcome of your instrumented cervical spine surgery. I'm hosting the webinar today with Philippe Bancel from Paris. Philippe, you may want to say some words, please.
Again, I would like to thank all you guys because very nicely you accept even very late in night to be with us to share time. And again, I would like to thank Oscar. He's involved in our committee of education, and he's done during the virus a very high job. And thanks a lot, you guys and the attendees. I hope we'll have a lot of people who just listen to us, and particularly you, Oscar. Young generation, good blood, young blood. This is great.
Good. So we are very honored to have on board very distinguished faculty from different corners of the world, from China, from US, from Brazil, Turkey, France, Portugal. And we look for a very interactive webinar and welcome your questions on the chat or raising your hand. Anna is our host as usual. And without any further delay, we go to Professor Avinash Petwarden. He's a good friend of mine. He's the most impactful biomechanical engineer, at least in my cervical practice, is professor of orthopedics, surgery and rehabilitation at Loyola University in Illinois and director of musculoskeletal biomechanics laboratory, Edward Hines. So he will give us a lecture on the biomechanics of cervical screws and useful tips for surgery, please.
Thank you, Oscar. You can hear me?
Yes, perfect.
Okay. Thank you for inviting me to this seminar. I'll just introduce my colleague, Robert Havey. He and I are both going to share this 10-15 minutes of time. So I am going to talk about biomechanics of posterior screw fixation for the occipitocervical junction. So occiput C1 and C2. And my colleague Bob will talk about our most recent study in the laboratory on subaxial screw applications, lateral mass screw, pedicle screw, and so forth. So without further ado, I'll begin. We have no relevant disclosures. So the occipitocervical junction, or C0, C1, C2, has a lot of mobility, almost 40% of flexion extension motion of the entire cervical spine and 60% of rotation. C1, C2, of course, as we all know, is the primary source for axial rotation. And there is, in a healthy junction, there is minimal translation in the anterior to posterior direction as well as in the axial direction. So just to give you some perspective, this junction provides almost 45 to 50 degrees of motion in flexion extension, and then almost 40 degrees of axial rotation on one side. So together close to 80 degrees of axial rotation from left to right, primarily coming from C1, C2. And of course, there is also some amount of lateral bending. So there are many many things can lead to instability, such as trauma, cancer, neoplasms, infection, and any inflammatory diseases. And spinal instability, I mean by that is abnormally large rotational or translational movement under physiological loads. This is as defined by Zedeble et al. So those are the times when we need to have internal fixation, and I'm going to talk about the posterior fixation. So briefly started out with wire techniques, screw plate techniques, and I'm going to today focus on the occipital screws with transarticular C1, C2 screws, with C1 lateral mass and C2 pedicle pars screws, or C1 lateral mass with C2 crossing laminar screws. So until the early 1900s, occipito-cervical instability was considered inoperable. In 1920s, first description of occipito-cervical fusion, there is a paper by Forrester. And then this is just a brief review. Then there is Galley fusion, Brooks fusion. Brooks fusion was an improvement over the Galley fusion technique, which is shown in the upper left. And then Halifax fusion, and I need to get rid of this bottom. In 1986, Magarol and Seaman described this transarticular screw fixation technique, and subsequently can you forward it? Looks like I'm stuck. Oh, there. So Magarol presented this technique back in '86, and then in Grobe in 1992 showed that C1, C2 transarticular screws provide significantly greater stability as compared to the wired technique and the Halifax techniques we saw on the previous slide. The anterior transarticular fixation is also an effective alternative instead of going from, it's a salvage procedure compared to the posterior fixation. They both have anterior as well as posterior transarticular fixation have similar biomechanical strength, unless you add cables to the posterior technique. Then there is the C1 lateral mass screw, along with C2 pars or transpedicular screws, as described by Goel and Lahiri in '94, and subsequently by Harms and Mercer in 2001. And finally, Wright in 2004 described the C2 crossing laminar screws. So the question is, can you include occipital bone in the construct? And the answer is yes. Career and Stark and those people, they have shown that rigid fixation using occipital screws combined with either transarticular screws or C1, C2, C1 lateral mass with C2 pedicle screws can significantly become a stiffer construct than just the semi-rigid wiring technique shown on the right here. In our lab, we did a study in conjunction with Dr. Sasso from Indianapolis on biomechanical evaluation of 3 segmental occipito-atlantoaxial stabilization techniques. So first, we took occiput C1, C2 in the intact state and measured its motion in flexion extension, lateral bending, and axial rotation under 1.5 Newton meter moment. And then we created instability by cutting transverse and alar ligaments, resulting in an anterior subluxation of C1 on C2 as shown in this diagram, in this X-ray. Subsequent to that, we did a transarticular, we did 3 types of fixation. Transarticular screws as shown in the lower left, and then both the right-hand side things are showing C2 crossing laminar screws coupled with the C1 lateral mass and occipital screw. This is just a photograph, and this is an X-ray. So long story short, this is the final result. The first series of bar graphs are for the intact specimen. Then the next is laminar, crossing laminar screws, pedicle screws, and transarticular screws. And on the vertical axis is the range of motion. So blue is flexion extension, then this is lateral bending, and orange is axial rotation. It's very clear that either of any of these 3 fixation techniques substantially reduce the range of motion in all 3 modes, and there is really no statistical difference between, in terms of immobilization between these 3 methods. And this is another way of looking at it in flexion extension. Again, this is the intact range of motion, 50 degrees, and then less than 5 degrees of motion with either of these 3 methods, laminar screw, pedicle screw, and transarticular screw. And same is the story for lateral bending and axial rotation. So all 3 techniques demonstrate similar biomechanical stability. One thing I want to note is we did not simulate any repeated loading or cyclic loading. So all these results of equal stability are only applied to one type loading and not cyclical loading. So the vertebral artery position and its course can determine which technique should be used. So for example, in this photograph we can show the proximity of the vertebral artery with the screw. And then we also did CT scans of our specimens to show that this is the transarticular screw, which is farthest away from the vertebral artery, whereas pedicle screws and transarticular screws are pretty close to the vertebral artery, so you have to be really, really careful. In terms of potential risk of artery injury, the risk is highest in transarticular screw, as you could see in this diagram, in this CT scan. Next is the pedicle screw with C1 lateral mass. And finally, the least risk is with the C2 laminar crossing screws. So finally, depending on the regional anatomy, and the 3 techniques are available to stabilize this occipito-cervical junction. And the surgeons can utilize any of these techniques depending upon the regional anatomy of the vertebral artery and the surgeon's preference or skill. So I now give it to my colleague Bob Havey to talk about fixation of subaxial cervical screw. So we'll save the questions for the end, right, Oscar?
Yes, please, Robert. So Robert Havey is a senior biomedical engineer and works in the same lab as Avinash Petwardhan. Robert, I'm glad that you made it to be with us. We can't hear you. Can you unmute yourself, please?
How's that, better?
Yeah, perfect.
Okay, thank you. As Oscar said, I work with Dr. Petwardhan. We've been together longer than most marriages. I think we're coming up on 33 years. So I'm going to talk to you about our laboratory experience with lateral mass screws and pedicle screws in the subaxial cervical spine. So as our populations in general age, it's these elderly patients that are more often meeting the indications for spinal fusions. And these elderly patients generally undergo longer fusions, and they may have diminished bone quality. And they're more often than younger patients undergoing posterior fusion. So there are a few options for screw types in the posterior subaxial spine, as Dr. Pat-Worden mentioned. Generally, the standard is lateral mass screw fixation. This is followed next by pedicle screws. Translaminar and transfacet screws are used less often. When we are looking at screw selection, as I said, lateral mass screws are used most often. And this is partly due to the fact that pedicle screws in the subaxial spine are somewhat technically demanding and generally require advanced imaging to make sure you stay away from the vertebral artery. So as a consequence, lateral mass screws represent a lower neurovascular risk, while pedicle screws do present a higher pull-out strength or better fixation than lateral mass screws. So from the literature, we find that lateral mass screws are most useful from C3 to C6, while pedicle screws are most useful at C7. So the literature shows or gives us a number of pull-out studies evaluating lateral mass screws and pedicle screws. And we can see just from these average numbers that there's quite a disparity between the two. If we look at these numbers as a factor, we can see that pedicle screw pull-out strength is about 2.3 times the strength of lateral mass screw fixation or lateral mass screw pull-out strength. But what's important to keep in mind that these numbers are highly variable. So they go from about 1.5 times as strong up to over 3.5 times. And this is quite dependent on the specimen, bone mineral density, age, gender, these kind of things, as well as the specifics of the experiment. With lateral mass screws, there is an increased risk compared to pedicle screws of screw loosening or fixation failure. And from the literature, depending on the study, this can be up to 12% of patients in a group or up to 4% of the screws placed. So it's these patients at risk of screw loosening that can benefit from better fixation. So this could be conversion to pedicle screws, can be a longer fusion to the upper thoracic spine or more cranial cervical spine. Or the topic of our research in this case was the potential use of supplemental fixation to the lateral mass screws themselves. So we undertook 3 studies. The first study in a motion segment, so these are all cadaver specimens. We evaluated lateral mass screws and compared lat fixation to lateral mass screws supplemented with a single tricortical transfacet screw. In the second study, we looked at lateral mass screws versus lateral mass screws supplemented with 2 unicortical screws. And in the third study, we looked at lateral mass screws with the 2 unicortical screw supplemental fixation, and we compared that to pedicle screws. All surgeries were done by 2 practicing neurosurgeons from C3 to C6. Specimens were age and bone mineral density matched, and the supplemental fixation used was the Dupuis-Synthes multi-point system. So briefly, the way the system works is after lateral mass screw placement, the rods are placed followed by the supplemental fixation bracket, and then the screws are placed, either the single tricortical transfacet screw or the 2 unicortical screws. So fixation strength was evaluated using screw pull-out testing, and testing was performed along the axis of the primary screw, be it the lateral mass screw or pedicle screw. Looking at the results from study 1. This is the lateral mass screw compared to lateral mass supplemented with the single transfacet screw and the motion segment. We see that we get a significant increase in pull-out strength with the supplemental fixation. Now you'll notice that these error bars are quite large, and that is primarily due to the fact that each vertebral body, or each motion segment rather, was its own control. And these, the bone mineral density, gender varied through the study. So we had a considerable standard deviation of the magnitude, although it is a significant finding. When we look at study 2, this is lateral mass screw supplemented with the 2 unicortical screws. We see also a significant increase in pull-out strength with the supplemental fixation. And as I said earlier, you get quite a large difference in the response between different specimens, and that can be seen in the 2 orange bars here. These are both pull-out strength of lateral mass screw fixation alone, so quite a disparity between groups. In the third group, we compared the lateral mass screw with the supplemental fixation, 2-screw supplemental fixation, to pedicle screws. And from this, we can see that between the 2 studies, the 2 blue bars, they're equivalent essentially. But pedicle screws do represent a higher pull-out strength than the lateral mass screw with the supplemental 2-screw fixation. So in our conclusions, if we normalize these findings to the strength, the pull-out strength of lateral mass screws, we see that the lateral mass screws with the supplemental fixation of 1 tricortical transfacet screw, the supplemental fixation represents about a 1.25 time increase in pull-out strength. With the 2 supplemental screws, the pull-out strength is about 1.5 times greater than the lateral mass screw alone. And from the literature, we know that pedicle screws are about 2.3 times, have a 2.3 times greater pull-out strength than the lateral mass screw. So this gives you an idea, sort of an increase or a choice on how much strength you may need versus the complexity of the surgery. With that, thank you.
Thank you, Robert. Very, very clear. So I think we should ask the questions at the end, probably, because we have biomechanical flavor with clinical flavor. So I ask Professor Zileli is our next guest. I'm very honored to have you here, Mehmet. He's professor of neurosurgery in Ege University in Izmir, Turkey, and former chairman of WFNS Spine Committee, president of Middle East Spine Society, president of Turkish Neurosurgical Society, president of World Spinal Column Society. So he's quite a well-known person in the spine field, has important contributions for education, training of spine surgeons worldwide, and also a prolific author. It's an honor to have you here, Mehmet. Please share your...
Thank you, Oscar. It's my pleasure to be with you. Actually, this is a talk which will deal with occipital and condyle screws. This is my presentation order. I will start with the indications of occipital-cervical fixation. Actually, absolute indications of occipital-cervical fixation are traumatic occipital-atlantal instability and occipital-atlantal instability due to basilar invagination, especially in irreducible cases, and tumors and infections at the joint and rheumatoid basilar invagination. However, the contraindication is occipital bone defects. You cannot use, if you cannot use occipital bone, you cannot do occipital-cervical fixation. In fact, if you look at the anatomy, occipital-atlantal joint is a very strong joint, and most of the problems at the region is from atlantoaxial joint. So it's a mistake for years. The spine surgeons are trying to do occipitocervical fixations in case of atlantoaxial joint problems. So in trauma, we must always look if there is an occipitocervical instability. If not, the main problem is C1, C2. Then we can make just C1, C2 fixations. Also in non-trauma, we can just look at the source of the problem and then behave accordingly. In basilar imaginations, if not reduced and need odontoid resections, and if C1 assimilated, occipitocervical fixation can be a choice. So there are problems because unnecessary occipitocervical fixations are being done, and this fixation restrict head movements very, very big amounts, and then there is a high non-union rate at the region. Technical evolution, if you look, we have come from bone and graft systems with casts to Lucke-Hartzell rectangles or Ransford loops with very old-fashioned things like hooks and U-shaped plates. And then we switched to Y-shaped plates since the midline occiput was thicker and then screw purchase was more strong. And we evolved by the time from very long fixation points to shorter fixation points. And recently we are using such modern systems for occipitocervical fixations. In fact, bone graft and cast, now occiput plate and polyaxial screws with shorter fixation, separate indications, and fixations after reductions. We came to a more evolved point. What about technical consideration? Best place is the midline occiput, an occipital plate or anchored to cervical rods, or cervical rod combined with a plate may be used. In and out technique may be used, and burr holes and wires can be used for children, especially with thin occipital bones. I will give you some examples. The midline occiput idea is very important. This is a rod screw systems. At the same rod, there is a pre-band plate part, which then fixate the occiput not in the midline. Probably these occipital plate systems are more commonly used and more popular. These are some pictures from my own applications. And another option is the wires with loops, plates, and bone cement. Like you can see here, you can open 4 burr holes, and then between the burr holes, you can switch, connect a multi-filament wire. This is a case of a kit. I have used such a 2 axis plates, and under the burr holes passing wires. Dr. Pate and co-workers have developed an inside-outside technique, but it has not been very popular. What about complications of occipitocervical fixation? There are multiple complications: CSF fistula, cerebellar hematoma because of puncture of the dura, hardware-related complications of screw loosening, pseudoarthrosis, and instrument breakage may happen. In Vaccaro's early series, they have reported 50% pseudoarthrosis or non-union rate. This is my own series published recently in European Spine Journal. We had different pathologies and followed the patients more than 6 years. And non-union happened if we are using allograft, low bone quality, severe deformities, and if there are hyperlordosis. This is a case of bilateral rod breakage because of non-union. This is a case of distal screw loosening of a C2 chordoma patient. We then revised it with the lateral mass screw and more modern fixation technique. In conclusions, we had almost 52% complication rate, and most of them were implant related. There were also wound problems, systemic and other complications. And we can say that all less rigid systems had more complication rates than recent rigid systems. What about condyle screws? This is a new advance, actually. If there is a deficiency of occipital squama for screw placement, especially if there has been a posterior-fossa craniectomy for foramen magnum decompression, or if there is a tumor removal of the region or a hematoma, if there is a malignancy and infection of occipital squama, if there is a revision surgery for failed occipital squama-based cryocervical stabilization, and as an additional augmentative anchors in a standard occipital plate screw construct, you can use occipital condyles together with the C1. It was first described by Lemarca et al., and they have used 3.5 millimeter diameter screws and 22 millimeter lengths. The entry point for screw insertion has been in that series 3 millimeter inferior to the vein for foramen in the midline of the condyle. This is this is another study from US surgeons. Trajectory for the occipital condyle screw can be like this. It is 5 millimeter lateral to the medial wall of the occipital condyle and at least 2 millimeter caudal to the skull base. So they have given a 20-degree medial angulation. And in the cranial caudal angulation, it was parallel to the skull base. And they have also looked at the condylar entry points with different angulations according to the skull base, and how can their screws jeopardize the hypoglossal canal, atlanto-occipital joint. They have examined that. And 5-degree cranial or 10-degree cranial angulations may jeopardize hypoglossal canal. However, 10-degree caudal and 30-degree caudal angulation can jeopardize the atlanto-occipital joint. That screw is also very close to the vertebral artery. It is above it, and then you must sometimes dissect the artery and then separate it from the ligaments. And there are the risks of injury to hypoglossal nerve, injury to the vertebral artery, injury to veins, and the biomechanical strength has not been well investigated, actually. I could not find good studies comparing the strength of occipital condyle screws with the traditional occipital cervical fixations. Another option is the atlanto-occipital transarticular screw, similar to the C1, C2 transarticular screw. Actually, this is you can see the pictures of that here. It was first described in 2003 by Dr. Gonzalez. So these are the options, and then I will conclude my talk that occipital fixation restricts head movements and has a very high non-union rate. And the main problem is the decision for whether occipital C1 or C1, C2 instability present. We must teach everywhere that in case of buzzer imagination, especially, we do not need, most of the time, we do not need to make an occipital cervical fixation. Most cases have only C1, C2 instability, and occipital cervical fixation is not necessary. Shorter fixations must be tried instead of going very caudal levels. And the condyle screws is an alternative only in case of deficiency of occipital squama, especially in previous surgery cases and in tumor and some trauma cases. I would promote our Cryovertebral Junction and Spine Society website. You can find many videos there in that site. Thank you. Thank you for listening to me.
Thank you, Mehmet. Very, very clear presentation. I think we are dealing the occipital bone and the condyles. I don't know if Avinash, are you there? Avinash or Robert?
No, I'm here.
Yeah, I think probably one of the advantage, you want to say a word of the biomechanical advantages of the condyle screws? I think one of the advantages could be that you are reducing the lever arm of the fixation. So everything is so close, there is no this big curve and big lever arm of the C0, C1, C2 fixation.
Yes.
So can you comment please, Avinash or Robert?
It depends upon.
Can you talk a little bit louder, please?
It depends. I would say it depends upon. It depends upon whether occiput C1 instability is there or not. If there is instability at both C0, C1 and C1, C2, then you'll have longer fixation is probably needed. Because with just the condyle fixation, I'm not sure over long time, I mean, over some cyclical loading, how strong will that be? Do you have experience with loosening of that?
Not really. Very, few very sparse cases. But Mehmet, do you think if the biomechanics is good, this could replace the occipital fixations?
No, I don't think so.
You don't think so?
It will not replace it because the anatomy at the region is not very easy for application. And if you are doing a occipital condyle to C1 screw fixation, the screw heads are very close to each other. So probably it is an adjunct to other options. And it's like C2 fixation, you can make many things, isthmus, pedicle, or laminar screws. This is something like that.
I tend to agree with him. Also, the occipital bone is much stronger compared to, I would think, compared to the condyle.
Okay, Philip, you have a comment? You might have used those before.
To Mehmet. Mehmet, I had in past a big complication with the occipital-cervical junction fixation. I observed just closing the angle. I had just after surgery a huge problem with impossibility to breathe for the patient, and we've been obliged to do a tracheotomy and to restore a normal angle between O and C1, C2. So Do you have this kind of complication and any recommendation to avoid this kind of disaster?
Yeah, really, it's a big complication, really. I agree with you. Actually, occipitocervical fixation have quite large complication rates, and then we must try to avoid as much as possible. Yeah, I admit.
Okay.
Okay, so I think we need to move to the next set of screws. So now we're talking about C1, C2 posterior screws, and Philippe will speak on the transarticular screws.
Do you see?
Marcel is professor of orthopedics in Paris. He's really the dean now of CSRS Europe, one of the souls, I would say. He leads the scientific and education committee. And although everybody knows that was the favorite disciple of Jean Debussy. It's a big honor, Philippe, to hear to you.
So you hear me, guys?
Yes.
Okay, you see my presentation?
Perfect.
Okay, again, I would like to thank all the Oscar first, and all the attendees and all your colleagues to share time and to share experience and just discussed. So Oscar asked me to talk about Magal technique and if I had some trick and tips. Okay, so when do we use this kind of technique for all pathology, in fact? And I used to use this technique when I had to treat rotatory dislocation, for sure, inflammatory disease like rheumatoid arthritis and ankylosing spondylitis with luxation of C1, C2. In degenerative cases like here with unilateral arthritis in traumatology, when you have to do a fusion in tumor and metastasis lesion, and even in young kids with congenital deformity. The goal of C1, C2 screw is to stabilize an unstable segment, as Mehmet say, to reduce a deformity, congenital, to immobilize a painful segment, a unilateral C1, C2 arthritis, and to reduce or to treat a fracture by posterior approach. This technique always needs a fusion, a direct fusion between the two, the facet of C1 and C2, or indirect, where you add some kind of bone posterior between the posterior arch of C1 and posterior arch and upper lamina of C2. You need a perfect knowledge of C1 and C2. So I'm not getting back, just having some information about the isthmus. The isthmus width is 4 millimeters in 90% of cases. This is your aspect when you're doing your surgery. This is the facet here and the capsule and the C2 nerve. So there is a limit in this technique. Abnormal way of the vertebral artery, we'll see that later on. High riding vertebral artery or predominant vertebral artery. When you have for rheumatoid arthritis, for instance, a big pannus posteriorly, and you are absolutely unable to totally reduce C1, C2, major local pathologic destruction. This has been described by Japanese people. And in case of rheumatoid arthritis with dense migration, we have 70% of wrong way of the vertebral arteries. And upper thoracic kyphosis. Just I would like to remember a story. We were at Barcelona for the cadaver course, and somebody asked me to do the Magol technique. And Bernard Jeanneret was there, and I said, okay, we have a specialist of Bernard of this technique, because Bernard was involved in the department of Magol. And so I asked him, and when you see that big kyphosis, it's absolutely impossible just to target the anterior arch of C1. So he really never be able to target the C1. So it was impossible. Even he was telling me before, we can do that every time. So again, before surgery, it is very important to do a CT angiogram just to know where is the vertebral artery. The technique, this is the aspect on cadavers. So you see the target and the direction of the screw and the direction of the screw, which is going to cross C1, C2 facet and joint. This is a view during surgery. What I'm doing, I'm opening the canal between C1 and C2 in order to see the canal and to see the cord. And I will see with the tip and tricks why I'm using this kind of technique. This is a classical description. Enter point, screw under the C2 inferior facet, 2 or 3 millimeters above C2's free facet joint. And afterward, the direction of the drill, the trajectory is pretty 0 to 10 degrees, very medially, as through the central axis of the C2 pedicle, but it's not the pedicle, in fact, it's the isthmus of C2, and at least 30 degrees upward. And what you target just here, the under arch of C1. So to summarize, enter point 3 millimeter, 3 facet. The drill is 2.5 millimeters for a screw of 3 to 3.5 millimeters screw. The sagittal target is the anterior arch of C1, and the axial is right in front of you. Alors, is there any tips and tricks? Maggle technique is not always possible. Before surgery, the surgeon must verify the feasibility and the plan B must be considered. The positioning of the patient may fare a halo, really immobilize the head, no movement of the head, large preparation if you need to go to the iliac crest, the shoulder must be lowered, and 1, even 2 fluoroscopy are mandatory. Most of rich country used actually multi-fluoroscopy too and navigation, but most of us have not this type of technology. The way of the screw differs between Maggle technique and pedicle screw. The enter point for Maggle is lower and more medial. Maggle technique is an isthmus technique which differs from pedicle technique. The direction is close to straight ahead and upward from Maggle technique. Pedicle screwing is 20 degrees to 30 degrees frontward and less ascending. Alors, is it possible to do this surgery without fluoroscopy? I can say that, but what I'm doing, when I'm doing this kind of surgery, I'm using only one fluoroscopy in profile. I have no things for anterior posterior fluoroscopy. I'm putting 2 spatula here. I'm opening my capsule. I repair my C2 roots, and I'm putting a spatula there and a spatula there. With a ronger here, I'm doing a decortication of the cortex there, and with a smooth current, I'm getting there. Okay. Afterward, I'm doing some kind of distraction of the joint here, as Bernard Jeanneret tell me, and with a drill and a pins, I'm crossing under my eyes here, this area, and finally it's easier to cross and to go to the lateral mass of C1. Okay. This is the aspect during surgery: the root, a spatula there, a spatula there. Here, the joint, you distract the joint and you enter slowly and slowly here. After decortication of the cortex, you enter some kind of curate mousse with a gauge, and you verify until you get to the lower part of the joint. Afterward, you use your drill, you cross and you screw. So it's some kind of freehand technique. But with this kind of technique, Maggle technique, the scar can be very big. Is there any danger of using this technique? When you ask Bernard Jeanneret, he said, no, we have never any problem. But when you have a review done by Masashi in spine volume about 560 operation, when you compare the number of vertebral artery between all the group and Magel technique, you see that the Magel technique is pretty dangerous. So this is my conclusion, and I would like to offer to come and to join us at Barcelona with André Combalia on June. Thank you for attention, guys. Thank you.
Thank you, Philippe, for taking us step by step to your technique. It's really wonderful. Can you unshare your screen, please? Yes, I did it for you. Okay, so now I'm going to talk on the C1, C2 screws, the goal arms technique. I have no disclosures relevant for this presentation. As Avinash said, C1, C2 is a highly mobile segment, and this raises special challenge for fixation. As you see here, it's almost 50% of axial rotation happens at the C1, C2. So it's real crucial to block axial rotation, which is best accomplished through transarticular screws or the goal arms technique, being wire and clamps biomechanically inferior. The range of motion at C1, C2 level is determined by ligamentous elements and also the joint anatomy. And you have the transverse ligament, which is the strongest ligament in the body and is the primary stabilizer. It allows rotation, which is counteracted by the contralateral alar ligament and facet joint anatomy, and allows slight sagittal plane translation less than 3 millimeters. And this already defines what is C1, C2 instability. If you have anterior atlantodental interval higher than 3 millimeters or a posterior atlantodental interval less than 13 millimeters, you are facing instability. Also, in some cases of fractures, if you have this rule of Spencer, lateral displacement of lateral mass of C1 over C2 higher than 7 millimeters. However, almost 60% of C1, C2 instability in case of fractures don't meet these criteria. So you have to pay attention to the MRI integrity of the transverse ligament. You can have bony avulsions of tau and interligamentous ruptures, as you can see here in the MRI. So what are the indications for C1, C2 fixation? Instability criteria, whatever kind of disease, degenerative, infection, tumor, rheumatoid arthritis, congenital malformation of C2, the os being the number one, certain types of C1 and or C2 traumatic fractures, atlanto-occipital instability, you should always come down to C2, or when you need to anchor occipital cervical fusions or long cervical thoracic fusions. These are the Geweiler classification of the atlas fractures, and what you see here, what you see here, it's really that the type 3B and 3B2 are the ones that you can treat with the posterior fusion. And also the type 4, when there is there is fracture involving the lateral mass, you should do this kind of operation. Of course, if you have on a type 3B2 minimally displaced fracture, you can use this kind of direct osteosynthesis, avoiding a C2 screw. Regarding the odontoid fractures, the Gower classification regarding the type 2 fractures, type 2C, where you have this kind of line of fracture, anterior inferior to posterior superior, it's a good indication for C1, C2 goal arms technique. Nevertheless, in this case of type 2B, we decided to do this posterior fixation instead of an anterior odontoid screw. There was a widening gap of the fracture, and it's a technique that we have quite of experience, and to avoid some of the complications of the odontoid screw, we decided to go from the back. The Engman fracture, also the type 2A and type 3, where you have angulations higher than 11 degrees, or facet joint dislocation, C1, C2 posterior fixation, it's a good operation. Of course, you have to rule out that you don't have a C2-3 compressive disc herniation, that you should do an anterior approach. as Philip said, for this kind of problems, we have the single screw transarticular, or we can have the two screws, the goal arms technique. It was described by Lecomte, later developed by Goal with plates and with rods by Harms. It does not require preoperative C1, C2 reduction as the transarticular technique. And the fact that you can put two independent screws, one in C1, one in C2, you can have a safer placement of the C2 screw. Ease of insertion, it's something easier between the transarticular, as Philip showed, very challenging, or the easiest one, the translaminar. Also, it harbors an intermediate risk of vertebral artery injury. Fusion weights are good, as comparable as the transarticular. It can happen, screw malpositioning. It depends on the published series. Of course, you have complications. You have C2 nerve root sacrifice or neuropathy with possibility of dural tear, spinal cord injury, and vertebral artery lacerations. Unilateral ones may be asymptomatic. Nevertheless, you should do a postoperative angiogram. If you have unilateral vertebral artery injury, you should leave the screw in place to tamponate and choose a translaminar screw for the contralateral side. Talking about the C1 screw, you have two possibilities, different entry points. The C1 pedicle screw, which is a long interface between board and screw. You can use longer screws around 34, 36 millimeters. Less dissection of venous structures, no mobilization of C2 nerve root, but difficult, as you can imagine, to get a good entry point, especially without navigation. And then the C1 lateral mass screw, the entry point is lower, and you use a partially thread screw of 20 to 26 millimeters that you aim 10 degrees medial and with a superior annulation. Be careful because you can have the arcuate foramen due to ponticulus posticus, and this will appear as a widened arch of the atlas in case you are using a particular screw in C1. Also, as you can see here, the entry point for the particular screw is very close to the vertebral artery. It's really a difficult one. When you do a lateral mass C1 screw, the entry point is really close to the V3 segment of the vertebral artery. So my advice would be to dissect around the lateral hand of the C2 ganglion, as you see here in one of my cases, and this should be done under microscopic vision and meticulous hemostasis. Be careful that sometimes the vertebral artery enters under C1 right in front of your entry point. So always look at the vertebral artery on thin cut CT. Also, you should avoid bicortical C1 screws, despite you can gain pull-out resistance. And why is that? Because the hypoglossal nerve, it's 2 to 3 millimeters lateral to the midline of the anterior aspect of the C1 lateral mass. And also the vertebral artery can lie within 1 millimeter of the screw exit in the anterior arch of the atlas. So this is really your corridor for the C1 insertion, and you should avoid too long screws as here. So never, you should probably stop at the anterior arch of the atlas. And due to the configuration of the joint, in order to avoid facet joint violation, the joint is like a bow tie, you should aim to the bottom 40% of the anterior arch of the atlas to avoid facet joint violation. The C2 screw, you can have pedicle or pars. The pars screw is very similar to the trajectory that Philip showed with transarticular screw. It's just a shorter screw. Of course, if you do a pedicle screw, you have a much longer screw. It can go to 36 millimeters with almost the double of the pull-out resistance. Here, it's one of my cases. We did actually one side transpedicular, and on the other side a pars screw. The entry point of the pedicle screw, it's always a little bit lower and medial to the entry point of the lateral mass screw, and you should always try to do rather superior and medial entry point to avoid hitting the vertebral artery. The books tell you that you should aim 20 degrees medially and 20 degrees upward. Normally, what I do is I rely on lateral X-ray to direct upward my pedicle screw, and I expose the upper and medial surface of the pedicle with you can palpate with the dissector, as you see here, and this will. And this is not a problem to injure the spinal cord because the canal here is very high, very wide. So you palpate the medial wall of the pedicle, and this gives you a good sense of the medial orientation of the screw. Be careful to the variations and anomalies of the vertebral artery. You can have persistent congenital anomalies of the vertebral artery, persistent first segment intersegmental artery. You can have an extracranial C1, C2 origin of pica. You can have fenestrations of the vertebral artery. And one of the major problems when it comes to inserting a C2 screw is the pedicle width. There is almost 25% of patients will have an unfavorable anatomy that will preclude the use of pedicle screws. As you can see here, it's virtually impossible to insert a screw. So always obtain fine cut CT in all patients prior to surgery, and in cases you have, consider CT navigation. The problem being, if you look at from the inferior aspect of C2, you have this medial and eye right vertebral artery, which can happen in almost 25% of cases, and bears a very high risk of vertebral artery injury. As you see, very difficult to pass this screw here. The isthmus height is less than 5 millimeters, and the internal height of the lateral mass is less than 2 millimeters. There are different kind of pedicles and loops, and always try to understand the relation between the pedicle of C2 and the vertebral artery in the patient that you are operating. It's possible sometimes when you have this superior medial loop of the vertebral artery by mobilizing the vertebral artery, as you see here, and get a good entry point to insert your pedicle screw. These are some cases that we have done with pedicle screws here, C1, C2. Always try to have very meticulous anatomy, good dissection, meticulous hemostasis. Here another case of os orthopedeum and the synovial cyst. And despite the fact that this was really a thin pedicle, I managed to insert a screw here with risks, but we were lucky. You can do hybrid screws whenever you face this kind of problems. Combine a pedicle screw with a translaminar screw. So these are challenging screws, and you see what you look for. You look for what you know. So you need to respect your own limits and have a plan B, A, B, and C. I would again also invite you to submit papers to our CSRS annual meeting in Barcelona in 15-17 June. Deadline abstract submission is 1st of March. Thank you. So next, I think we have Leopoldina.
Yes, I'm here, Professor.
Please
Can you hear me?
Yes, yes.
Okay. Can you see my screen?
Yes, so Leopoldina, she's one of our most diligent residents. She's very knowledgeable and very interested in spine, and she will talk us about the C2 translaminar screw fixation. Please, Leopoldina.
Thank you, Professor. Hi, everyone, and thank you for the invitation. It is an honor for me to be here. So today I'm going to talk about C2 translaminar screw fixation. So it was in 2004 that Wright described for the first time the C2 translaminar screw fixation for patients with trauma, neoplasm, pseudoarthrosis, and degenerative disease. And this technique was not inferior to the other techniques in terms of biomechanical stability. Clinically, this technique can be successfully used to obtain occipital cervical fixation, atlantoaxial fixation, and incorporation of C2 into subaxial cervical spine fixation. When we are going to perform a C2 translaminar fixation, it is important to know some anatomical considerations about the lamina of C2. So according to this cadaveric study performed by Wang with 38 patients, the C2 lamina had a mean width of 4.3 millimeters, and they reported that the maximal average of the screw length that could be accommodated was 31.6 millimeters, with a range from 27 to 37 millimeters. And this cadaveric study also shows that there is a great variability in the size and morphology of the C2 lamina, because on 37% of the patients, at least one side of the lamina would not be able to accommodate a 3.5 millimeter screw with a 1 millimeter margin of bone around it. And almost half of the patients, 47% of the patients, would be unable to accommodate a 4.0 millimeter screws bilaterally. On the same study, the mean lateral angulation of the screws down the lamina was 44.1 degrees, with a range from 37 degrees to 50 degrees. And we also know that the C2 lamina is predictably large and represents the largest cervical lamina. So it is likely that this technique could be applicable to a large group of patients requiring fixation of C2. So with its anatomical considerations and anatomical knowledges, this study concluded that the rare situation in which translaminar screws cannot be placed is much less common than the 20% incidence of unfavorable anatomy seen with C1, C2 transarticular screws or C2 pedicle screws. And we know that there are some anatomical tips that can be useful while performing this surgical technique. For example, we know that the screws should be placed down a trajectory that is slightly more in the cornal plane than the lamina, because if there are any bone violations, would occur dorsally rather than ventrally into the spinal canal. And it is also recommended that the first screw must be as cranially as possible on the junction of the spinal process with the lamina, so that there is enough room for the second screw from the opposite side. And if we are going to do a fixation with fusion, we know that on one of the sides, the amount of laminar decortication for arthrodesis has to be limited, since it can weaken the screw purchase. So one of the major advantages of this technique is the decrease of the risk of the vertebral artery injury. And we know it is a less technically demanding technique than other C2 fixation. And the entire screw path can be directly visualized or palpated with instruments, so intraoperative navigation may not be needed. And another advantage of this technique is that we can achieve bicortical fixation, and furthermore, it is a versatile technique, allowing the incorporation of fixation extending to occipital, atlas, and subaxial cervical spine. However, on the other hand, there are some disadvantages with this technique, because we know that the C2 translaminar screws cannot be used if the patient needs decompression at the C2 level, and attaching a rod to a laminar screw could be difficult on the first times. And a CT scan before surgery is highly recommended in all studies due to the large variety of the morphology of the C2 vertebra. So what about the biomechanical studies? We know that there are some biomechanical studies related to the C2 translaminar screws in conjunction with C1, C2, occipital C2, and C2 subaxial constructors. But the largest collection of biomechanical evidence pertains to the use of the C2 translaminar screws on the atlantoaxial fixation. So in this study performed by Gorex, he reviewed the biomechanical of C2 translaminar screws on the atlantoaxial fixation. He used odontoidectomized cadaveric model to compare the C2 translaminar screws with C2 pedicle screws with hybrid C2 translaminar and pedicle screws. And he concluded that all three fixations yield statistically significant reduction in lateral bending, flexion extension, and axial rotation movements. And apparently, no statistically significant differences were observed between the three constructions. On another recent study performed by Dmitriev, he directly compared the C2 translaminar screws with C2 pars screws and C2 pedicle screws, and all three instrumentations significantly reduced axial rotation, flexion extension, and lateral bending. And after they performed odontodectomy, they realized that the C2 pars screws and the C2 pedicle screws outperformed the C2 translaminar screws in lateral bending, and the C2 pedicle screws recorded the highest pull-out strength, but the C2 translaminar screws had significantly greater pull-out strength than C2 pars fixation. This is one of our cases performed in our hospital. It is a 69 years old female patient with a chronic neck pain and occipital pain, and she developed a progressive tetraparesis with a motor grade 3 on the upper limbs and motor grade 4 on the inferior limbs. And as we can see on the MRI, we can see occipitalization of the atlas with basilar invagination and spinal cord stenosis, mostly on C0, C1, and from C3 to C5. On the pre-op dynamical cervical X-ray, we can also see the atlanto-occipital simulation, and on the flexion, we can see a little anterolistesis in C3, C4, and C4, C5. On the CT scan, we can also see the basilar invagination and ossification of anterior and posterior longitudinal ligaments. So the patients underwent a small posterior fossa craniectomy to remove the posterior arch of C1. And as the patient did not need a C2 level decompression, we only performed laminectomy from C3 to C5. And then we performed fixation with fusion from occipital to C5 with occipital plates, C2 translaminar screws, and C3 to C5 lateral massive screws. With 8 years of follow-up, the patient persists with a tetraparesis, but with a significant improvement in the right upper limb and significant improvement of neck pain. This is another case of our hospital. Is a 70 years old male patient, and he presented with an asymmetric tetraparesis with motor grade 3 on superior limbs and motor grade 1 on the inferior limbs after falling from a tree. On the CT scan, we can see an unstable Jefferson fracture and atlantoaxial subluxation and a T1 fracture. On the MRI, we can see an atlantoaxial ligament injury, a fracture and luxation of a C71 with stenosis of the spinal cord with hyperintense spinal cord signal from C4 to T1. So in this patient, he underwent a C6 and C7 laminectomy, and the superior part of the lamin of T1 was also removed. Then we performed a fixation from C6 to T1 and an independent fixation from C0 to C2 with occipital plates and C2 translaminar screws. This is a good example of a case with a long instrumentation from occipital, cervical to dorsal spine. And as we can see, this clinical case demonstrated a technical issue that may arise with C2 translaminar screws, which is the difficulty in incorporating these translaminar screws into a rod construct, long instrumentation, owing to the medial position of the screw head, which will require a substantial rod bend. More recently, this issue has been addressed by the inclusion in some modern spinal instrumentation systems of an angled offset connector designed specifically to alleviate this problem. And another technical tip to deal with this issue is to leave the screws 2 to 4 millimeters broad to allow for screw head rotation, as well as to close the distance between the tulip and the rod, which diminish the bending of the rod. This is the last case that I'm going to show you is a 47 years old man with a malformation of axis with orthodontoideum, and as we can see on the x-ray, he had a C1-C2 instability, and the CT scan showed a high-riding vertebral artery that deeply indented into the pedicle facets of the C2 vertebra, more on the right side. And on the CT scan, we can also see a widening atlantodental interval, which causes a spinal cord stenosis on this level. So the patient first underwent to a C1-C2 fixation with hooks and rods due to a myelopathy with spastic tetraparesis, but the patient persisted with tetraparesis, a severe neck pain, and a severe disability. And on the dynamic X-ray, we can see an atlantoaxial instability and a C1-C2 subluxation. We also performed an MRI on this patient, and we can see a C1-C2 severe stenosis of the spinal cord. And on the dynamic MRI, we can see the movement and the instability of the odontoid and anterior arch of C1. But apparently, there wasn't a lateral instability between C1 and C2. So the patient underwent to another surgery to remove the hooks and the rods, and we also performed a decompression by removing the posterior arch of C1. And due to a high riding vertebral artery and a small C2 pedicles on the right, we performed a high risk, a C2 hybrid fixation with C1 lateral massy screws, with C2 pedicle screws on the left side, and a C2 translaminar screws on the right side. And on the post-op CT scan, we can see reduction of the atlantoaxial instability, and the atlantodental interval also decreased, and there was a significant reduction of the spinal cord stenosis on C0 and C1. We know that atlantoaxial instability and high-riding vertebral artery cases are very challenging, and this case demonstrates a good resolution with a hybrid combination of C2 pedicle screws and translaminar screws on the side of the high-riding vertebral artery. There are few studies about C1-C2 hybrid fixation like this one. This is a study with 11 patients with high-riding vertebral artery and atlantoaxial instability, and all of them underwent to a C1-C2 fixation with hybrid C2 pedicle translaminar fixation. And with 3 months of follow-up, all of the patients got relief from the neck pain. The visual analogical scale neck pain decreased to 1.6 comparing to 5 on the pre-op, and the MJOA score increased to 14.4 comparing to 11.3 on the pre-op. And with 2 years of follow-up, there was no failure of internal fixation, pseudoarthrosis, or instability. So in this study, they concluded that the hybrid fixation technique provided a favorable bone union and clinical relief from symptoms. And patients with a normal vertebral artery or osseous anomaly are good candidates for the hybrid translaminar screw technique. So in conclusion, this technique decreases the risk of vertebral arterial injury, and it could be applicable to a wider number of patients. And the direct visualization or palpation of all relevant structures makes the operation easier and faster, and intraoperative navigation may not be needed. Most of the biomechanical studies showed that the C2 translaminar fixation was equivalent to pedicle and transarticular screws in flexion, extension, and axial rotation, but not in lateral bending. And the hybrid fixation should be considered as a rigid alternative for C2 pedicle screws with a normal vertebral artery or osseous anomaly. Thank you very much.
Thank you, Leopoldina. Very nice and detailed clinical cases. I think we can close this model and open to questions. I have given the word to Mr. Charles Davis from UK. Mr. Davis, are you there?
I am. Can you hear me?
Yes, please. I know you have a very provocative question. Please go ahead.
Well, first of all, it's an excellent webinar, and the last presentation, because I'm old and retired, my father worked for Jefferson, so that was 90 years ago. At any rate, 1985, I was a neurosurgeon for the assisting Ransford for the first loop. I, as a neurosurgeon over many years, have been concerned about the use of screws, particularly in inflammatory arthropathies, such as rheumatoid. I did about 200 Ransford loops and Hartseal loops for the subaxial spine. I think that sublaminar wiring is something that is more difficult to do and has fallen out of favor because it's more difficult to do. However, when the bone is bad, I think, watching my orthopedic colleagues, that screws can be difficult and fall out and fail. And I'm very pleased to see the honest results of several speakers of screw failure. Sublaminar wires and rigid fixation, and for atlantoaxial, I've always used C1 and C2 and C3. By pulling on C3, you can pull the C1 laminar back. But C2 laminar is very strong. It's an excellent thing. And if you get, and I also have always used cement, something that will horrify perhaps everybody, a lot of it. I've only had one failure in that small inflammatory arthropathy. So the question is, when the bone is poor, what's the use of screws? Thank you.
Thank you, Mr. Davis. Pity that we didn't see you, we just hear you, but anyway, feel free to open your video. Philippe, you might want to answer to Mr. Davis.
Yeah, good morning and good afternoon, and thank you for your very nice question. Yeah, I totally agree with you, because I used to do surgery for a while like you. I'm 69 years old, and with Jean Dubousset, we use a lot of hooks. First of all, wire with Roi Camille. I agree with rheumatoid arthritis. A lot of technique that is absolutely not possible. Just because for Magel technique, sometimes with a panus, it's absolutely impossible to reduce C1 on C2. And due to the fact that as soon you have a dense migration, you have a total restriction of the area, and sometimes it's really impossible to screw with a major risk for the vertebral artery. It's a reason that plan B with hooks, wire, everything you want can be used, and most of old guys still use this kind of technique, even it's not really recognizable on international society. So finally, I agree with you.
Thank you.
Thank you. Any other question on the topic? I'm sorry, we had a small hacker here, so we had to close the question and answers. And but anyway, feel free to raise your hand, and I will give you the voice, and you can ask questions. So I think as Philippe said, you have to be comfortable with the technique that you know best, and certainly you should not apply the same technique to all patients. And patients are different, and you should tailor the technique to different patients, to the pathology that you are facing. And the good thing is to know different tools in your armamentarium of options. So if we don't have further questions, we can always come in at the end. I'm calling, now we move to the anterior screws, C1, C2 screws. And I give the word to my dear friend, Fernando Dantas from Brazil. He's vice president of Brazilian, oh yes, Avinash, sorry.
There was a question, I think Ali from China.
Yeah, I have a question. Thank you.
Okay, you do better moderation than I do, Avinash.
I have a question.
Yeah.
I have performed a lot of C1-2 dislocation. The question is for parallel, right? Because if the dislocation is reducible, perhaps the strength from posterior will need very strong. On this condition, if the high right vertebral artery exists, do you still choose the laminar screw? This is my question, because I think it needs a strong. So I don't think it is enough for C1-2 reduction. How about your opinion?
Well, you know, I can tell you that, and it's a pity that Leopoldina didn't show this case, but we had cases with reducible C1, C2 basilar invagination that we could easily reduce with a C1, C2 translaminar screw. Of course, this is not the case for every patient, and the most difficult reduction you have, you need to do other kind of surgeries, release the C1, C2 joint, and probably if you at the same time have a high right vertical artery, probably learn to do your technique and go from the front. That's probably what needs to be done. And you know, we'll hear certainly from you about that topic. But in more mild cases of basilar invagination is easily reducible. If you have a high right vertical artery, you can do a translaminar screw. We have done that in the past, and we can reduce it. And we all know that all posterior approach, if you apply distraction, that you produce some kyphotic effect, which is not good as well. So that's probably one of the advantage of your technique. But we can discuss that later, if you don't mind.
Okay.
So I'll call now Fernando Dantas from Brazil. He will talk us about the odontoid screw. As I said, Fernando is a friend. He's vice president of the Brazilian Neurosurgical Society. He is the boss of neurosurgery in Hospital Biocor in Belo Horizonte. And he has also some background and training in France, which I think Philippe is glad about that. Please, Fernando, go ahead.
Good morning, good afternoon, good evening, everyone. Thank you, Oscar, for the invitation. Oscar asked me to talk about anterior odontoid screw, indication, technical types, and trips. So, a good result with the use of the anterior odontoid screw based on the association of these factors. Number one, indication. Number two, of course, the contraindication. Number three, meticulous preoperative radiologic evaluation, and of course, the surgical technique. So, for the treatment of odontoid fractures, I prefer use the Rockamille classification, as we believe it's more compatible with the surgical strategy, and because it takes into account the height and the direction of the fracture line you can see here. So, the Rockamille fracture, the horizontal fracture type 1, oblique posterior fracture type 2, and anterior oblique fracture type 2, very important, the differences between two fractures you can see here. So, the indication of the anterior odontoid screw, of course, the fractures acute and subagude, at least less 6 months. The two types of the fractures, the horizontal fractures and oblique posterior fractures. Only the two types of the fractures is indication for anterior odontoid screw. Of course, more important than indication, the surgery, of course, the contraindication. The number one contraindication is anterior oblique fractures like this. Another contraindication is all the fractures, lesion on the transverse ligaments, significant osteoporosis, of course, inability to archive anatomical reduction, or of course, inability to archive appropriate screw placement. So you can see here some example of the contraindication absolute of the use of anterior odontoid screw. Anterior oblique fracture, like this, you can see here. Or the fracture, you can see here, like this. If fractures, non-reductive fractures, like you can see here, or you can see here. Contraindication absolute of the use of the anterior odontoid screw. So another contraindication, of course, some contraindication it's relative, some contraindication it's absolute. So like this patient, for example, a patient with the fixed cervical spine, it's difficult to impose the neck extension or flexion. Another patient with a short neck, another patient with the habitus body, and another patient with the barrel shaped gaster, where it is the proper patient position and access to anterior neck. So some patient, it's a contraindication absolute, some patient contraindication relative, you can see here. Another point very important is the meticulous preoperative radiological evaluation. For example, if you take a look at this image, we will only see the fractures of the odontoid like this. But look better at the X-ray of the skull. You can see here some change like this. In fact, the patient having Page disease, contraindication absolute of anterior odontoid screw. Another case, you can see here the same thing, and serious fractures odontoid with the posterior deplasma, but look calm, you can see here the patient in fact have a clipper file C2, C3. So very important meticulous evaluation preoperative in all the patient. Another important measure is to be done used CT scan preoperative to measure the ideal length of the screw that will be used. With this technique, the surgeon is be fast. You can see here the measure of the length of the screw. You can see here the base of the odontoid, just the apex of the odontoid. Just for demonstration, the diameter of the odontoid is almost 90 millimeters. The length of the odontoid almost 45 millimeters. It's very important. You can see here, just an example, the patient CT scan preoperative. Look, the length of the screw, almost 40 millimeters. You can see here the same size and the same length of the preoperative. So the surgeons are more fast and more easy. It's very important to avoid the situation. Look, a very big screw, then relationship C2 body. So if the patient have the preoperative measure of the length of the screw, you can avoid that situation. And finally, of course, the most important, I think, is the surgical technique. They are step by step, they have to be followed to carry out this procedure. Number one, anesthesia, position, alignment of the fracture, screw trajectory, anterior cervical approach, choice of the screw entry point, drill, and of course, the screw. So, carrying the surgical technique begin, of course, with the anesthesia and surgical position. So the patient should be positioned at supine on the operative highly transparent table. You can see here. The arms may be gently tapped down the side with the mid-thresher. You can see here, of course. The endotracheal tube positioned on right side or left side to improve the visualization of the odontoid anterior posterior plane, of course. And the patient accompanied with the Gardner, you can see here, or on flexion, you can see here. Another step very important, bite block weight of gaze or winding cork may be used to keep the mouth open like this for improving the AP visualization. Used by planned fluoroscopy, of course, if you have, obtain quick AP lateral view of the odontoid during all the procedure. The anatomical alignment of the fracture side by initial position or intraoperative reduction is vital to the success of the procedure. A reduction can be done with the help of the anesthetist, but you can see here with the threshold on preoperative, you can see here, with avec the Gardner, in post-operative, the alignment very, very good. Another thing you can see here for alignment of the fracture, a fracture reduction maneuver to access reducing flex or extension. You can see here, inflection or extension. You can see here, it's worse, the fracture. Like this, the fractures completely alignment. Those the maneuvers to reduce the alignment of the frets. Another maneuver, you can make the light manual trashes, like in this case, you can see here, just for alignment of the odontoid fractures. The fracture reduction, also, by anesthesia, logicista, by impression posterior, or pressure does the multi-anterior ring of C1, but it's not necessary the majority of the time. The next step is checking whether the screw passage will present defect to the cast opposition. So you can see here, the screw trajectory is then checked on the lateral view. You can see here, the key wire laid alongside the neck. So in this patient, you can see no problem to passage of the screw. You can see here. But in some patient, like in this patient, with the buried gas, very difficult to the passage of the screw in some patient. You can see here. So the checklist. Once again, attention for the C-arms positioned for perfect at AP and lateral view. The fracture to be positioned by anatomic alignment of the fracture, and of course, check the screen trajectory, of course. So, after the precaution, the surgery begins using a classic anterior cervical at the level of C4, C5, or C5, C6. Using classic anterior approach, it must be necessary use the frontal light to visualize the site of the surgery. So just for demonstration on classic anterior approach. So this point for me, the most important point of the tips and tricks in the anterior approach screw. So the entry point of the screw. So enter the C2 body at the C2, C3 disc under the anterior edge of the body. And so the very entry point screw, it's here, it's not here. You can see here. A midline anterior inferior aspect of the body of C2 to provide adequate visualization of the anterior inferior and plateau of C2. You can see here, just for demonstration, the entry point of the screw. So entry point of the screw, you can see here. I believe that is most important point of during the surgery. So just for demonstration, on key wire or drill, advanced and surface for anterior inferior corner of the body C2, you can see here. In the proximal fragment, slowly and careful, though the type of the odontoid, you can see here. Just for the material used for introduce the screw, the majority of the time, the screw diameter 3.5 or 40 millimeters, and the length of the screw 15 millimeters. So another example, just for demonstration, the screw advanced under fluoroscopy control, you can see here. For demonstration, the screw cannulate, you can see here, you can see here, you can see here. So the good position of the screw, you can see here on this slide. So just for on case, you can see here on fracture of C2. Once again, demonstrating the entry point of the introduce of the quire. And drill guide, you can see here, anterior inferior lip of C2 and the midline, of course. A pneumatic drill and real-time fluoroscopy AP in lateral view. Use to monitor progress until the drill arriving at the tip of the odontoid, penetrate the cortex, the odontoid tip, you can see here. AP in lateral view in real time, you can see here. So, real time AP and lateral view. Another point, after the drill, after the QR, you can fed the measure of the screen length. You can see here, for example. Just for you to know what length of your screw you can see here. Another point, very, very important, you can see here, this detail of the bony thickness of C2 that's required for a good screen position. Very, very important. So you can see here a good position of this screw. You can see here the bony C2. Of course, some defect encountered in some patients, for example, the patient with body habits and very, very difficult, maybe inhibit access to proper trajectory for screw placement, very, very difficult in the patient. Another defect encountered if the guest is better shaped like this. Yeah? The drill will not be able to get low enough, very, very difficult, but sometimes you can use the malleable drill to introduce the screw in situ. Another difficult if the neck has a fixed flex, very, very difficult to introduce the screw in situ. Another difficult encountered, of course, is a poor fluoroscope visualization, like you can see here. Of course, the bad result is screen mal position like this. But take time to ensure good AP lateral view fluoroscopy before beginning the procedure is a key element to success. You can see here lateral view. You can see here one AP visualization, good visualization. So during this initial setup, effect reduction, you can increase or decrease amount of traction maybe helpful. Like this patient, I use the 8.5 pound. You can see here complete consolidation 2 years later. Another point, before drill the odontoid, the fracture can be alignment reduced completely, of course. Sometimes, if the fracture is high in the odontoid, the tendons of the partial tendered screw, like this, maybe across the fractures, prevent the compression. Sometimes I use this, but it's not necessary the majority of the times. So, if problems occur before or during the procedure, it may be necessary to abandon attempt at fixation and switch to a primary C1, C2 posterior fixation. So the bad result, two things, bad selection of the patient, more bad technique. So you can see here, this patient, bad technique. The entry point is not here, the entry point is here. This patient, bad selection of the patient, the old fractures. This patient, bad selection of the patient, anterior oblique fractures, pull out of the screw. Another patient, bad selection of the patient, displacement more important. So bad result equal bad selection of the patient, more bad technique. So in conclusion, careful selection of the patient and meticulous surgical techniques is necessary for surgical success. Thank you, Oscar. Thank you, everybody.
Fernando, thank you. Thank you. Wonderful, wonderful presentation, that reflects your huge experience. So I think we should move to the next speaker, Aifusi from China. Will talk us about anterior transarticular screws. Aifusi is professor and director of spine surgery at Sun Yat-sen Memorial Hospital and University, and he lives in Guangzhou, China. Aifusi, thank you so much for being so late with us. We are very eager to hear your presentation, which is something new, at least for me, for my experience. Please share your screen.
Okay, thank you. Thank you, Oscar. Can you see my presentation?
Yes, just put on screen mode, please.
Okay.
Perfect. Perfect.
Hello, everyone. The topic, my topic is anterior transoral, transpaticular, and transarticular mass screw, or C2 technical node. And I'm from Guangzhou in China. First, I will talk about the classification and the treatment of attentor axial dislocation. As we know, it is always be divided into 3 types: reducible, irreducible, and fixed subordinate dislocation. And now I will focus on the irreducible dislocation about the C2 and anterior screw. For the irreducible dislocation, I will always perform the anterior transoral release and followed by anterior top fixation. The main reason of irreducible dislocation include the basilar invagination and the old dense fracture. If this kind of dislocation cannot be reduced by traction, we will always perform the top procedure. That means transoral Atlantic axial reduction plate fixation. And the first operation of TAP 1 was performed on April 2003. So far, more than 600 cases of TAP operation were accomplished, and about 160 to 70 upper cervical spine cervical operations were performed every year in my department. And this is the process of TAP operation. I'll show everyone. Here is the normal C1-2 and the dislocation. After release, you place the plate on the anterior surface 1, and here is the C2 temporary screw. In the retractor, we can elevate the C1 together with the plate, a superior reduction and then posterior reduction. After that, we will place the C2 pedicle screw and take out the reductor and the C2 screw and the bone fusion. Now I will introduce the history of TAP. The first operation in 2003, you can see that the C2 vertebrae was immobilized with unicortical screw. So it is not strong enough. You can see that dislocation in some cases. So we changed our idea to TAP 2, the second general. You can see that the C2 screw have penetrated the post cortex of the vertebrae of C2, and so many surgeons will they ask us that the screw has penetrated the post cortex, so it has a danger to injure the spinal cord. So we changed our idea to TAP 3 in 2007. You can see that it's the it's the transoral reverse transpedicular screw. So it is very difficult because from a big vertebrate body to find the thin pedicle is very difficult. So I think a lot of ways made it successful. After that, in 2009, we changed it to TAP 4 with polyaxial locking mechanism and with 6 hole. For every patient, we will make a 3D model so that we can simulate a C2 screw insertion for every case to make it easy. This is TAP 4. During the operation, you can see the plate onto the anterior surface of C1-2, and during the from the fluoroscopy, we can see that dislocation has got stellar reduction, and here is the C2 anterior transoral reverse pedicle screw. The ideal screw entry point should be 3 to 4 millimeters beneath the medial extremity of the prominence of C2 articular process. And sure, no high-red vertebral arteries is needed. And the direction should be aimed 20 to 25 degree inferiorly relative to the articular facet C2 in the sagittal plane, and aimed 25 to 30 degree laterally in the axial plane. Here is a case of a typical case for a reverse transpedicular screw of C2. You can see that the pedicle screw is from anterior to posterior in an ideal position. Well, in the case of basilar invagination, because the C2 vertebrae is more high, so we think another way for substitution of the reverse transpedicular screw, and I called it transarticular mesh screw. You can see that the screw is just underneath the surface of C2 facet joint, so it is more horizontal. In the actual plane, you can see that the angle is just the same with the transpedicular screw. And because of the higher C2 vertebrae and the influence of the upper knees, so the insertion angle of transoral screw of C2 should be more horizontal than that of transoral transpedicular screw in the sagittal plane. And you can see that it is the transpedicular screw trajectory is the transarticular mesh screw. The transarticular mesh screw, the trajectory will more more horizontal. Here I will show you the surgical procedure of TAP. It's a typical case of TAP 3. TAP 3 is 4-hole. You can see here, after the anesthesia, the dislocation cannot be reduced. And after a thorough release from the bitracheal approach, we placed a TAP with 2 C1 screw and fixation. They become a hole. I will place the reductor. I will show you how it get a reduction. Dislocation, reduction. After that, we will place the C2 screw. It's the key point for this section. And you can see that when the hand drill touch the posterior edge of the vertebrae, if you feel the bone, bone is very stiff and cannot penetrate, perhaps the direction is wrong. You may adjust the direction laterally. Generally, it will be medially because we are always afraid of injure the vertebral artery. So I always should adjust laterally. If from the fluoroscopy, you can see that it penetrates the posterior cortex of the vertebrae, but it's still in the bone. So we can palpate that it is just in the bone. So it was in the right trajectory. It was in the pedicle. So we can just penetrate the bone and immobilize with the screw. On the counter side, we will perform the same procedure. After that, it was the plate was immobilized with 2 transpedicular screws. You can see that it's very, very perfect. And here is some tips for the screw insertion of C2. The direction of the hand drill should aim superiorly to the fossa of the C2 vertebral artery, and that means that it's higher than the upper edge of the lucent area. And if the upper teeth, you can see teeth here, we will show the upper teeth. The upper teeth is higher. The transpedicular screw of C2 has a condition to perform. And if the upper teeth are lower, the transarticular mass screw will be safe and effective choice. You can see that the transpedicular screw and the transarticular mass screw. And we must obey some basic security rules. The screw trajectory should be oblique rather medially than laterally. You can see that the the yellow lines means that it had penetrated the cortex of the vertebrae, but it's safe. The red line is perfect transpedicular screw, and the white line shows the injure the vertebral artery. It will be a disaster. And the screw trajectory in the sagittal plane should be oblique, rather cranially than caudally. You can see the yellow line means the transarticular mass screw is safe, and the red line means the transpedicular screw is perfect, and the white line is disaster, able to injure the vertebral artery. So if both lateral vertebral artery injury or dominant vertebral artery injury happens, the cerebral infarction will be inevitable, and it's the most dangerous complication. Here is some case for C2 anterior transpedicular screw. Here is a BI patient, 32-year-old male. You can see that the dislocation, and from the dynamic view, you can see the dislocation is very rigid, and the C1 lateral mass had dropped onto the anterior surface of C2, and the odontotic process has go into the foramen magnum. The spinal cord is compressed seriously, so we performed the patient with TAP with the reverse transpedicular screw of C2. You can see that the screw is very perfect, and compared with the pre-operative X-ray, you can see that C12 had get thorough reduction. And compared with the pre-operative CT scan, you can see that it gets still thorough reduction. And the facet joint, the C1 lateral mass has get its anatomical position. And the C2 anterior transpaticular screw is in good position. And the spinal cord is decompressed thoroughly, and the CMA is recovered to normal. After 3 months follow-up X-ray, you can see that it's still in a good position, and the spinal cord is decompressed thoroughly. If you have all-arm navigation for the screw placement of C2, it will be better. Why? Because the C2 transpaticular screw is relatively dangerous. So if you have all-arm navigation, it will be better. Here is the BI patient, a 64-year-old male. You can see that the dense deformation and this even after the posterior decompression, it is unsuccessful. So we perform the type of procedure by the transoral approach. You can see that by the all-arm navigation, you can see that the transarticular mass screw is very easy, so that it's accurate and successful. By means of all-arm navigation, we'll get excellent results. You can see that the C2 transarticular mass screw is very successful. So compared with the preoperative X-ray and CT, you can see that the C12 had get a thorough reduction. So take-home message: transoral reverse transpathic screw implantation C2 is the best choice for the treatment of irreducible Atlantic axial dislocation with anterior C12 plate fixation. And the transarticular mass screw placement is the alternative method, which could supply with thorough fixation strength, especially for BI, because it is more horizontal, and it has for the danger of injure the vertebral artery will be less than the transpaticular screw. So it is I prefer to this one for BI. And the third, vertebral artery protection is the most important consideration for anterior transpaticular screw fixation of C2. And if you want to perform the anterior fixation of C2, I think this two screw technique is very important, especially the freehand technique must be grasped. Well, all-arm navigation will supply with safety and accuracy. Thank you.
Thank you, I foresee. Always very impressive. Listen to your technique, great presentation, and how your concept evolved over the years. I'm always amazed how you can reduce those BIs without posterior manipulation of the joint, without releasing the posterior muscles that are really strong. And congratulations for the results. I think we can discuss a little bit here between odontoid screws and your technique, Philippe.
Yeah, I have a question to you. Congratulations, I'm really impressed. Some of your cases have been done by freehand. My question is, in your huge experience, did you have any vertebral artery injuries? And how did you manage, if in case of? You heard my question?
Okay. Vertebral artery injury is a very important complication. In my department, I have performed totally about 600 cases. The vertebral artery injury only once from the other surgeon in my department. In my hand, no one in vertebral artery happens. So I think you must grasp the technique. If you can't make sure, you can't decide if the screw is in the right place, you must stop at the just penetrate the posterior cortex. You must stop, because you don't know if it was in the vertebral canal or in the vertebral artery canal. So you must stop just penetrate the posterior cortex. Okay.
Thank you.
Welcome.
You know, I think for those cases where you have very oblique vertical C1, C2 joint, your technique is really useful compared with the posterior traditional approaches. Fernando, what do you think about this surgery? You are very.
I'd like to thank us for the opinion, but I have one question for the professor.
Okay.
What's the advantage of the transoral transarticular technique than anterior transarticular classic? Can you hear me, Professor Fuzzi?
Okay. Okay.
I repeat the question.
Yeah.
You can you repeat your question?
Okay. What's the more advantage? The transoral transarticular technique, like you show, the anterior transarticular classic.
You you ask me.
So Fuzzi, I can translate from Brazilian.
Translate a little complicated.
No,
I can't hear clearly.
the question between your technique and the classical transarticular when you use only 2 screws, one each side. I think this is the question, right, Fernando?
Yes.
I think Fernando,
compare with the traditional anterior surgery, I think my technique is very important for irreducible Atlanta axial dislocation. If we can get a thorough release, then we must place a plate on the anterior surface. Anterior fixation, well, as we know, that is Harm's plate is the earliest plate by transoral approach. So we developed this technique and gave it instant reduction function. So after that, we must fix the plate in very strong, and in the first and the second generation the plate it is very strong enough. So I think that these two kind of screw of no matter transpaticular or transarticular mass is very strong enough. So we have performed a lot of patients and give the basic test, including biomechanics test. It proves that these two kind of screw is very strong enough for the internal fixation. Compare with the posterior particle screw, it has the same performance. So I think this kind of technique will helpful for irreducible Atlantic axial dislocation. Thank you. Okay.
You're right. I think the anterior classical transpedicular, you need a reduction of the luxation. Otherwise, it's not advisable. But I think we need to thank you. We need to move on to our last set of lectures on subaxial screws. And I invite André Joaquim, Associate Professor at University of Campinas, Brazil. He was past director of the Spine Department of Brazilian Neurosurgical Society. Everybody knows Joaquim. André Joaquim is a prolific author, more than 10 papers a year, maybe. Always a pleasure to hear and read you, André. Please talk us about lateral mass screw fixation.
Hello, everybody. Thank you very much for the invitation, Dr. Oscar. It's a great honor to be here. Well, I'm going to talk about lateral mass screw fixation.
André, please put on the screen.
Screen Can you? Play. Are you seeing my screen?
But not the screen play mode.
Well, just a second, please.
Yeah, no?
Share screen again.
Okay, yes.
Okay.
Yes, no.
Are you seeing my screen? Can I start?
Perfect.
And thank you again. Good morning, afternoon, and evening for Dr. I. All the content of this talk, with the exception of the case in these articles about subaxial cervical spine screw fixation that we wrote with Dr. Dan Rue. And just to start a preliminary talk, the cervical spine, we call subaxial cervical spine from C3 to C7 because the morphology of the vertebrae are very similar. And it's important to emphasize that generally there is no vertebral artery at C7. And this is important because we can use pedicle screws at C7 more safety than in the subaxial cervical spine. When we need to fuse the cervical spine, wiring techniques were not used anymore, with the exception of children's or some centers, because they have a right rate of shoulder throws once they do not provide immediate stabilization. You have to use a brace after surgery. And then the screw rod-based techniques are considered the gold standard, the modern techniques for fixation, because they have right fusion rates. And in the cervical spine, lateral mesh screws are the most used, probably because they are generally safe. I used to say in my residents that they need to know how to put cervical lateral mesh screws, even if they do general neurosurgery, if they don't become spine surgeons. Well, what is the lateral mass? The lateral mass is the bone area between the superior facet joint and the inferior facet joint of the subaxial cervical spine. This fixation is can provide high fusion rates. And there are two basic principles: to angling laterally the direction of your screws to reduce arterial injury. And so you go lateral to reduce arterial injury, and you go cranially because it reduces facet violation. For instance, you can see my mouse here. If you go direct straight, you violate the facet joint. And if you use a caudal entry point, you can achieve the nerve injury. So it's important to go laterally and cranially. And it was introduced a lot of time ago by Roy Camilli in 1974. And many other authors changed and provided a specific technique for lateral mesh screw fixation. Anderson and Magiro are the most recent and probably the most known. It's important, despite the technique you choose to fixate the lateral mesh, it's very important to have a CT scan preoperative because you have to evaluate the lateral mass size. There are lots of anatomic variations. So I used to say that I don't measure in my screw length in the CT preoperative only, but I use it as a parameter. What are the indications to lateral mesh screw fixation? It's everything you can use for instability from trauma, infection, tumors, degenerations, and it's very, very stable. But in patients that have severe instability, you may have to use another techniques. So it's also useful because you can put a lateral mesh screw fixation in patients that you do a laminectomy, a decompression. As I mentioned, in severe instability case, you have to be careful because they are small screws compared with pedicle screws. So we're gonna talk about this with case examples. And in pathological process that involve the lateral mesh, for example, tumors, you should not put screws. You have to go up, you go above, or you have to do circumferential fusions if the bone quality is too poor. I'm gonna discuss about the main techniques briefly. The first one was Roy Camilli, just in the center of the lateral mesh, a slightly lateral angulation, and the screws is 90 degrees the insertion of the screws. These techniques, it's easy to violate the facet joint compared with Magiro. Posteriorly, Nazaire and Lewis, they provide the entry point is 5 millimeters medial, 3 millimeters inferior to the superior portion of the lateral mass. The screw was inserted straight ahead in 90 degrees with the sagittal inclination. This is very easy to reproduce, but it can injure the vertebral artery. Magiro modification probably is one of the most known. It's the center of the lateral mass, a little bit above 1 millimeter above and medial, 20 to 30 degrees lateral angulation, and the sagittal angulation, this is very important, is parallel to the adjacent facet joints. You can use the fluoroscopy to have this inclination, or you can palpate the joint to give you your direction. Then you can, this technique is probably one of the most used, but if you use longer screws, you can have nerve injury. And techniques, again, a little variation, more caudal than Magiro, more lateral, and the sagittal inclination is cephalic. They are all small variations of one technique. This is the technique I use. Then most of the case I performed this technique. That was, I learned it and we published with Dr. Ru. And why? Because the entrance point is in the center of the lateral mass, 1 millimeter median and 1 caudal. But the lateral angulation and sagittal angulation are not angle-based. They are anatomic-based angles. So it's more accurate and reliable if you can teach someone that you have to go lateral in the upper corner of the lateral mass, and the sagittal angulation is toward the upper corner of the lateral mass. You can also use the radioscopy. This is pretty easy in reproduction. My criticism to the other techniques is that because it's very difficult to put 10, 20, 30 degrees, we don't know about that. Residents used to ask, oh, I'm 30 degrees, 20 degrees, I don't know. So if you use anatomic parameters, it's easy. The only point that there is some problems that when you go to C6 or C7, the spinal process, when they are large, they can get the way of your angulation, but it's easy. Only a specific talk that C7 lateral mass is very short. We generally put pedicle screws or laminar screws at C7, but if you want to put lateral mass, for example, in a case that there is no too much instability, you have to use a superior entry point and shorted screws, because if you go down, you violated the C71 facet joint. Here are some cases that I'm going to discuss the clinical use of lateral mass. The most common indication for me that I use pure cervical lateral mass screws are cervical myelopathy involving only the subaxial cervical spine. Here, C3, 4, 4, 5, 5, 6, and C6, 7 is fused. So we do a classic laminectomy in the area of the cord compression and the fixation using only lateral mass screws. This is another case that I have to go to C7 because C7 was involved. So once there is not too much instability, you can use safety lateral mass screws at C7. I like to emphasize that generally you cannot use very large screws at C7 lateral mass. The other use of lateral mass screws, for example, this is a patient with ankylosing spondylitis and a severe fixed dropped head, I can say that a fixed neck deformity, a kyphotic. And then we have to do a large osteotomy, and as much as I can put more fixation points, I put a lot of lateral mass screws, and I try to have a more strong screw. So I put C2 screws in the pedicles to reduce. Here I have a lot of lateral mass screw fixations because it's a long arm lever. There's a lot of strain in the construction. So I have to use pedicle screws because they are strong where it's safe, and the lateral mass to improve the strength of my fixation. Here's a case also that it's a deformity, but it's less severe. The instability is not so severe that you have a very good reduction with tension. We did a posterior fixation only with lateral mass screws, C2 pars screws, and small posterior osteotomies. This is a kyphosis after a laminectomy, another use of lateral mass screws. For craniocervical junction, generally, we don't go to the lateral mass, but there is some case, this is a basilar invagination patient that has also severe subaxial cervical spine cord compression, not only craniocervical junction. In the most of the case, we do only occipital C2 fusion, but in this case, we go subaxial, we combine with laminar screws. We have connectors, decompress the subaxial cervical spine, decompress the craniocervical junction. We realign the craniocervical junction, and we go down because we're using lateral mass screws once this case demands a more extensive procedure. For trauma, another example, this is a trauma that comes after more than 30 days. We could not reduce it anteriorly. The reduction was poor. So I flip it over. I don't put a plate. I flip it over and supplement with posterior lateral mass screws. Another case, this case I was planning to put some pedicle screws, but the bone was too poor. The pedicle was too difficult to visualize in the X-ray. It's a fixed deformity after trauma that they removed the screws in the past. The patient has this. So we use a lot of lateral mass screws, a connector, pedicle screws in the thoracic spine with some osteotomies to correct the thoracic kyphosis as well. And you see that you have a very good result after surgery. And this is another use of lateral mass screws. In children, this is a tip. We have to have a system that has short screws, 80 or 10 millimeter screws. This children has an infection, was operated in another spine division, comes to us with this, the infection was not controlled and he developed a kyphosis. There is some fusion in the posterior cervical spines. You can see that very small lateral mass screws. The plate was not fixed. We did an anterior approach to reduce the deformity, flip it over the patient, and even in children, we can have some lateral mass screws. This is 8 millimeter screws and some pedicle screws at C2, C7, and T1. You see that we achieve a very satisfactory result. My taking home message about lateral mass screws is that you can have a high arthrodesis rated. You have to know multiple techniques because you can combine that according to your experience in the patient's need. I'm not very enthusiastic about pedicle screws in the subaxial cervical spine, except if you have navigation. So I used to combine lateral mass screws with C2, C7 or thoracic pedicle screws. You have to evaluate the anatomy of each patient and choose very good implant system because it can provide you connectors, extension to thoracic, extension to the occipital. So this is my message, and I emphasize the use of an anatomic parameter instead of only angulation. Muito obrigado, obrigado a todos.
Thank you, Andre. Always wonderful lecture as always. So I think we need to move on, and we'll ask questions at the end, Andre. So we're closing with a golden key, and we have Don Courage. I think everybody knows him. He's a core figure in the world of cervical spine surgery. He's chair of WNS-CNS joint section on disorders of spine and peripheral nerves. He's president of International Society for Advancement of Spine Surgery, and he works in Carolina. You will talk us about MIS transpedical screws in cervical spine. Dom, are you around?
Absolutely.
So I'm curious about your lecture because not only the inherent risks of transpedicular screws, but also you have to do a lot of soft tissue dissection in order to get a good trajectory and good entry point. So I'm curious to hear your MIS technique.
You got it. Let's let me get my slideshow going. Let's see. Are you guys seeing that?
Yes, perfect.
Fantastic. Well, thanks, Oscar, for putting together a great symposium. You keep teaching me every weekend. I get to learn something new. So every day's a school day. It's good to see you, Pat, as well. I always enjoy your lecture, Pat. And so here's my disclosures, my crew in Charlotte. We've got a kind of a big group. We've got about 44 neurosurgeons and orthopedic surgeons. And we've heard some excellent talks today, including the preceding one by Professor Joachim. There is no doubt, though, that traditional open approaches to the cervical spine are associated with significant morbidity. We've all seen the posterior cervical decompression and stabilization multi-levels, where we have the muscle atrophy and the big bowing of the spine, and it's aesthetically displeasing with high rates of infection and instrumentation prominence. So this is a problem. There is no question that pedicle screw fixation has become a standard of care for thoracolumbar fixation. And several studies really dating back to the 90s, including Abumi, have described the feasibility of pedicle screw fixation in the cervical spine. But as Professor Joachim discussed, it's potentially a dangerous procedure because of the anatomy. But if we go to the biomechanics, there is no doubt that pedicle screw fixation provides significant biomechanical advantage over lateral mass fixation. We see the lateral mass fixation on the left, and we see the concept there that in addition to the fixation, you can see the smaller screws and how that they are angulated away from each other. Conversely, we see with the pedicle screw technique, we see much bigger diameter screws, longer screws in the triangulation. And so the biomechanical advantages are significant associated with pedicle screw fixation. And here's just a biomechanical study that was done that shows actually, this is impressive because it shows that even with the standard the standard screw size, here's a pedicle screw and here's a lateral mass screw. So we're not taking into account the trajectory, the larger diameter, the longer size, but just then is 4 times stronger to go into the pedicle. And so if you add those other factors, it is almost a factor of 10 stronger fixation if you use pedicle screw fixation. We also know the anatomy in the cervical spine, and Oscar, you just kind of referred to it in that it can be difficult to get into the pedicles, especially in the mid subaxial spine. We see here at C4-5 and C5-6 that we're extremely lateral in the cervical spine. So if you're going to do an open technique, you have to do all that dissection. So it becomes even more morbid to do that. So in open pedicle screw fixation is not only technically challenging, but it's just as morbid, if not more morbid, than your standard lateral mass fixation. So so you look at it and you say, okay, pedicle screw fixation is so great. Why aren't people doing it? And there are small pedicle sizes we've talked about. We just looked at the anatomy of the medial angulation, and we all know the adjacent neurovascular structures, the vertebral artery, the nerve root, and the spinal cord. And it's a relatively small corridor. So that's why people haven't been doing this. But as we've had in our evolution of navigation and intraoperative O-arm and intraoperative navigation systems, this biomechanically robust fixation technique that has not been utilized because it is so technically challenging has really become a very feasible MIS technique, and I'll kind of walk you through it a little bit. But the MIS technique circumvents the drawbacks associated with the open, like we talked about. We talked about how lateral you have to be, and you commented on it, Oscar. If you're going to do it open, that is just every bit as morbid a procedure as if you were doing it doing lateral mass fixation. But if you were going to do a muscle splitting technique, which is really the hallmark of MIS techniques in the thoracolumbar spine, it's not that you're using smaller incisions, it's that it's muscle splitting technique and you're going through the muscle and you're not pulling it off its bony attachments, and you don't get the same sort of atrophy and bony changes, and you actually get a much more advantageous angulation to your screw. And we see one of the extended tabs here that we utilize, and you see how here's a diagram of kind of how that would look with a percutaneous pass of the rod. Here's something that we published in IJSS last year, and it was really a proof of concept case series. And we'll talk about that for just a second. We had 27 patients with our group in Carolina, and John Pelosa, who was at Plano at the time with Texas back, he's now out in Colorado. But you see what we used it for. There were some complications. This was literally our first pass at it, but there was no vertebral artery damage. There was no nerve root damage or spinal cord injury whatsoever. So it was really just a proof of concept series. And since then, we've been working on the technique and continue to look at it in a prospective fashion. The best way to talk about the technique is not to talk about it, it's to show it. And so I'll give a couple of case studies. This was the actual very first case that we did with this technique. It was a pretty dramatic injury with a C6-7 fracture dislocation. You see with the CT scan that it's a complete spinal cord injury on the MRI, but this is certainly going to be a 360 sort of procedure. The anterior plate was done by one of my partners in the middle of the night, but that was not enough to hold this kind of unstable fracture. So we wanted to back it up, but we wanted to decrease our morbidity because we knew that this was a patient who was going to be quadriplegic and was going to be laying on the wound. It was a trauma patient, and we know about the high rates of wound problems, including dehiscence and infection. So this, to us, was a perfect example. So how do we do this procedure? We position in the prone, standard position. You have to prep very wide because, like we talked about, the trajectories are much more lateral than you would think they would be. And this is done under navigation, and it's used with the O-arm. And so this is what the pre-op positioning looks like. Here's what the drape looks like. The first thing we do is make a 2-centimeter incision and just place the reference frame. So before doing anything else, we place that reference frame and we do an O-arm spin. Now we have the O-arm spin, and we use that to guide our entrance points. And so you see very lateral incisions that are done here. We're using an O-arm to decide where there should be. We make one skin incision, but there are multiple different fascial incisions. So you're not taking down, like you talked about, Oscar, at the beginning, you're not taking down all that muscle. You're just cutting the skin and doing separate fascial incisions. And through that, putting percutaneous extended tab screws, and then the rod is passed percutaneously. So it really is a muscle splitting MIS technique. So the technique is pretty straightforward. We see here with one of my residents, Vince Rossi, who does a great job, and he and I have done a bunch of these together. But you're looking at the screen for most of the time. You can see the incision and then the separate screws with the extended tabs. And now here's the rod pass that is a percutaneous rod pass as well. So you drill your pilot hole, you do your power tap, you place your screws, you pass your rod, and then this is how it looks at the end. And you can see you have an incision here in the middle where you placed your reference frame. The incisions are very lateral, and you're not taking this dissection down to the bone, Oscar. You're just taking it to the fascia and using separate stab incisions. So the morbidity of the muscle morbidity is much less, and then you get this phenomenal fixation. And if you look at the pedicle screws, if this were being done with lateral mass screws, you typically would have to go several segments up because you're not just getting that same powerful fixation. Instead of just going 1 or 2 segments up, you're having to go up to C2 potentially to get that kind of fixation. So you're really saving the patient morbidity and operative time, I think. And again, here you have the final upright X-rays. You see the anterior construct, but the medial angulation of the posterior construct, the robust nature of the fixation. And then we talked about the implants. And if you think about the implants that are typically put in for lateral mass are 3.5 diameter by 12 or 14 millimeter screws. Look at the screws that are being put in here, 3.8 diameter, 4.6 diameter. Look at the lengths, 26, 26, 28, 34 millimeter screws, longer, wider, stronger screws with a better lateral to medial angulated trajectory. It is tremendously powerful from a fixation perspective. And you say, well, great, that patient's quadriplegic. What about patients who have neurologic intact? So here we have a 69-year-old who has a tumor, and he presents with a pathological fracture. And so you see on the MRI, the fracture involves the vertebral body, and it's totally replaced the vertebral body, but also the posterior elements. So we feel like this is also a very unstable fracture because it involves the facets posteriorly, and you see the facets there as well. So you see he has an anterior procedure with a PEEK cage, so you can image him post-operatively better. Now here's his posterior procedure with his reference frame. The pedicle screws are being placed and you can see the reduction towers and the percutaneous rod placement. Here's the reference frame at C7. And then here's your screws after intraoperative, after the rods have been passed, but before the reduction towers have been removed. Look at this medial lateral trajectory and this angulation. These are incredibly powerful fixation. And you see here, we close with Dermabond. No collars are utilized because the fixation is so powerful. And the aesthetics of the wound is much better because the patient is not laying on the wound. And most importantly, you're not doing that dissection down to the bone and pulling the bone off, the muscle off the bone. You're going through the muscle with a muscle splitting technique. And then here's the last one I'll give you. And this is an 88-year-old, but a very functional 88-year-old. So he's on a ladder at age 88 in North Carolina, as they're apt to do. Can't tell him not to get on the roof or go deer hunting. And so he presents neurologically intact, but he has a very bad injury. He's got a 3-column bony chance injury, and he's got an ankylosed spine. Can't get an MRI due to his pacemaker, but he is intact. He is actually seen by a different surgeon and recommended for a C2 to T2, which was a very reasonable option, but the family asked for a second opinion. And then we saw him, and you see his fracture. It goes through the end plate, but all the way through the posterior elements, including the pedicles. So with an ankylosed spine like this, he's neurologically intact, and this is a problematic case. Here's the consent form that was actually signed by the previous surgeon. And you see he was actually consented for C2 to T2 fixation with lateral mass fixation. And you can see when we did this was done about a year and a half ago. So that was the original, but then they got a second opinion, and we said, wait, we can do this percutaneously and we don't have to do that kind of morbidity. And you see the reference frame placed at the bottom affected vertebral body. You can see all the pedicle screws with the reduction towers, the percutaneous rod placement. Then here is screws going in. Here's incisions. This is from his trauma, not from our operation. You can see the lateral incisions. And this is how his collar looked after 24 hours. We threw that in the garbage. He never had another collar. And again, we know that these people, older people laying on their incisions, a lot of morbidity, a lot of infections and wound dehiscence. Here is final upright x-rays. We lost about 50 cc's on this case. And you can imagine what a C2 to T2 would do. This patient was mobilized post-operative day 1 and was discharged from the hospital on post-operative day 2, 88 years old. Look at the screw trajectory of the lateral to medial. So there are some challenges, like we talked about. If this were so great, why doesn't everyone do it all the time? And the reason is because we're just now catching up to the navigation. This needs to be heavily navigated. You need to be comfortable with navigation. There is a limited ability to do a decompression. All the cases I showed were either decompressed anteriorly or didn't need a posterior decompression. There's relatively limited space for bone grafting, and you have to be very facile with your navigation accuracy. There's no question about it. This is basically a fully navigated procedure. But it is feasible with our modern techniques. And it's unbelievable biomechanical fixation, no collars ever. lesser levels done, no more C2 to T2. Typically, you can go one level, one above, one below, in very unstable, two above, two belows. You preserve all that posterior musculature. You don't get the same accuracy. You don't get the same, atrophy, the same wound problems. It's ideal for trauma cases. We also use it for C1, C2 cases, and we didn't talk about that because my talk was about subaxial spine. And with further advances with MIS and decompression techniques, I think this will even become more prominent a technique. I thank you, Oscar. Thank you for everyone's time for involving me in this great symposium. I would invite everyone to come to the spine section meeting next at the end of this month, the February 23rd to the 26th. We're in Las Vegas. We're going to have a live meeting, and we're looking forward, and we'd love to see everybody there. Thanks for your time.
Thank you, Dom. Wonderful, awesome presentation. I think we'll hear more of this technique from other groups in the future. It has a lot of potential. You showed this very nicely. So we are open to questions to the last two lectures. And Andre, are you there?
Yes, I'm here.
Hi, Andre. You know, you're going to the OR, sorry. You know,
yes, I just changing my clothes.
I really enjoy your talk. It's just a very brief comment. There are different techniques. You mentioned the anatomical technique. You know, I tend to do what could be called the biomechanical technique, which is insert the longest screw that you can. You know, starting really low, medial, and going to the upper anterior superior corner.
I agree.
You know, remove the spinous process to be able to do a good angulation. So that's really what I teach to the residents, is to do the longest screw you can, get the best purchase you can, and if you do it like that, you are successful, and it's a very good option.
I agree with you completely.
So we have here in the audience very high-profile surgeons: Ben Ali from Morocco, Redeli, Demetriadis, which is the president of ANS. Combalia. I invite you all these guys to come and ask questions. Urelli from Italy, friends, Roder, Castagnoli, Mauro, good friend as well. So please raise your hand and I will give you permission to give some, ask a question. Philippe.
See you, Dom.
Hey, Pat, how are you, buddy?
Good, wonderful talk.
Always good to see you, my friend.
I had not seen this talk from you.
Maybe we have to do some biomechanical studies, you and me, on that, my friend.
Love to do that. Good to see you.
Good to see you.
Bruce Stardin, are you there? Very active member from the US. Okay, Philippe? Okay, I don't know.
Philippe's muted, I think. You're on mute, Philippe.
I have a question to Professor Dom. Can I do that?
Absolutely.
Professor, excellent talk. I think it's the future. I would like to ask you, without navigation, what do you think about subaxial pedicle screws?
It's a great question, and I think that I would never do it in a million years. It's amazing to me that Abumi published in the 90s and in the early 2000s, and he talks about his open technique, and they use fluoroscopy. It's amazing to me, and I think you have to be an outstanding technical surgeon to even consider it. And quite frankly, I would never do it. This is, to me, is 100% navigation technique, especially minimally invasive.
Yeah, that's my impression, that the pedicle screws in the subaxial comes back again with the O-arm, because they were published in 1994 and not so much used since there. But with the O-arm and navigation techniques, it comes back again because, of course, it's stronger. And I think it was important to use with navigation only. I don't feel comfortable to do subaxial cervical spine as well.
I'm not that good a surgeon.
Thank you very much.
Thank you. I enjoyed your talk.
Just a comment. Excuse me. I have just a comment. When we asked to the Cervical Spine Society European section, who used in the faculties this kind of technique, pedicle screw in the cervical spine, very few people in Europe use this kind of technique, except for very selected patients. So Oscar, what you think about that? I mean, using regularly this kind of technique?
No.
Very few people use it in the United States. This is really a new technique.
Yeah.
This is, a new MIS technique. We're very excited about it, but I'll let Oscar ask. But this is not a common technique. This is kind of brand new.
Yeah, I agree.
That's why I'm enthusiastic about the DOM technique. It's navigation. You can reduce complications, the vertebral artery, nerve root, and spinal cord. And certainly you reduce a lot the morbidity of the soft tissue dissection, which I think it's the big problem for this technique as well. So I think more people will grab this technique for sure, Dom.
Yeah, I think there's a lot of positives, and like Professor Joaquin was talking about, you need to have intraoperative navigation, and you need to be facile at it. And I want, we did this in cadavers before we did it in humans, and we have O-arm in the cadavers, and then we started out with people with spinal cord injuries, and then we eventually had degenerative conditions and tumor and everything else. We've probably done about 50, 60 cases, and I don't think anyone else is routinely doing this. There's some variations on that theme, but in terms of the subaxial pedicle screws like this, I think there are a lot of advantages, but it's a new technique and it needs to be vetted. And that's why I was not being facetious when I said, we'll talk to Pat about doing a biomechanical study and looking at some of the advantages and continuing with the prospective clinical study.
And I know, Don, that you do this also for C1, C2. I've seen cases of yours, and it was really remarkable result as well.
I think it's actually better and easier for C1, C2. It actually is an easier technique and you don't have to be as facile at C1, C2. There's some pratfalls, but I think if I were starting out, I would start out at C1, C2 and then move to the subaxial spine.
I have a question, very technical question. Are you bothered by the kyphosis of the thoracic area when you enter the rod? Do you understand what I mean? Because there is.
I do. You're not, because you're so lateral. And I think it's hard to get a feel for how lateral you are. At the beginning, when we first thought about doing this technique, we were afraid we'd be making two incisions and they would only be 2 or 3 centimeters apart from each other. And we were worried about the intervening tissue. But the reality is that the incisions are several centimeters apart, and you're really away from that kyphosis, and you could kind of take a lateral to medial angle. But we haven't had a problem. I imagine if someone had a truly remarkable kyphosis, you would have a problem with that. We haven't done it for deformity cases at this point. It's really been tumor trauma and some degen cases.
Thank you very much for your answer. This is great. Very great. I am really impressed.
We have now 2 hours and 40 minutes of webinar, and I'm really pleased that we had on the peak audience on Zoom and New Surgical TV and YouTube was really high numbers, good numbers. So Philip, do you want to say some final words? I thank all the faculty and all the attendants. It was really awesome webinar. We'll try to replicate more, probably in 1 month or 2. I was thinking about doing one about cervical osteotomies. It's a nice topic, so we are working on that. Philip, please say the final word.
Just a thanks to you, Oscar, for organizing this type of teaching. Thanks the attendees. We have been close to 70, and the faculties, because what we learn from all the world, very new technique like done with this transfer approach, etc. Even I'm getting old, there is always technique and new technique, and it's really exciting. So really, guys, I learned from you, and I really thanks all all of the participants. Thank you again, Oscar. This is what I wanted to say.
Okay, so see you next time.
And
Thank you,
bye-bye.
Anna, for hosting the webinar.
Yeah.
Thank you once again.
Merci.
Thank you, Oscar.
Everybody.
I don't know
Thank
if
you,
you
Oscar,
know
for organizing it.
we have been hacked by some Russian, but anyway, we moved on. And it was
Thank you
not a
very
big
much.
problem.
Thank you, guys.
Thank you so much.
Bye.
And bye-bye.
Bye-bye.
Bye.